Hello, and welcome to the EHE Myth-Busting podcast series, and thank you to everyone for listening. I'm Gareth Tucker, the CEO of a medical communications group, and I'll be your host for this podcast. This is the fourth in a comprehensive 5-part series funded by the European Hematology Association, discussing hematology diseases, diagnosis, assessment, and treatment in older adults. The purpose of the podcast series is to share up-to-date information with patients and physicians about hematology in older adults. To access the other podcasts and associated resources from this series, please visit the EHA campus at www.ehaweb.org. The topic for this podcast is hematological changes in older adults, and I'm joined by Professor Monica Engelhardt as our expert for this podcast. Professor Engelhardt, would you like to introduce yourself and your background and expertise?
Yes, thank you very much, Gareth, for the nice introduction. I'm a attending physician at the University of Freiburg. I deal with multiple myeloma patients, also with the study unit at our hospital. We have approximately 400 multiple myeloma patients that come to our site, and I'm specifically interested in elderly aspects of myeloma and its disease and possibly certainly improvement whilst the disease is better known and better treatable.
Thank you, Professor Engelhardt. So to begin this podcast, we have some topics for discussion that have been sent to us by Anita Waldmann, who leads the Leukemiahilfe Rhine-Main Patient Support Group in Germany. And Anita has asked, geriatric assessment is used to help physicians recognize frailty and guide treatment decisions in elderly patients. In your clinical experience, how receptive are patients to undergoing these tests and understanding their outcomes?
Yeah, I would say it depends really how excessive or extensive you want to do those testings. At our site, they very much agree to those tests, even if they are a little more in depth. What we have looked at for years now is a specific myeloma score that is being scored within seconds. So it looks at organ function, Knowski performance status, frailty, is the patient falling, self-sufficiently looked at home. Can he, she do whatever they like at home, or are they dependent on someone? And age plus cytogenetics are included in the score. And we also have a homepage where you can score those issues very quickly. That helps you with the definition, and that is done. So whether you do this whilst the patient is visiting or being seen by you, or whether you do this when you have seen the patient and do a workup of how treatment should be modified or done, it's up to you. Or we also use that in our multiple myeloma board. But the patient always agrees, so this is not at all of a problem. It's only if you tell those issues to colleagues that they fear it might be too complicated.
Interesting, thank you. So in your experience, how interested are hematology patients in connecting with other patients? What do they perceive as being the benefits of this?
It certainly depends on the patient. So there are patients who are very supportive of self-advocacy groups, so they like them. They like the people, they like to be in interaction, they have friendship with different patients, and they feel supported and also sort of being looked at, and they can share their fears and sorrows and joys and experience and whatever. And there are some patients who dislike this, or they are already well connected, or they have family and friends, and they're use this group as their sort of small support groups. However, in my experience, also looking at wider self-support groups, as Anita Waldmann has one, or the Deutsche Support Group of the Krebshilfe in Bonn, they are very much stretched out, so they have all the political issues that are needed, and they are well connected with politics and also with industry. So it does help to have those in your clinics and being in contact with them, to reach out and achieve higher goals. So I think self-support groups are very important. And actually at our Comprehensive Cancer Center, we have a professorship specifically for this issue to really foster and let those self-support groups grow. However, I mean, they really have to support patients. So I have, for example, one example where a patient is approaching a self-support person and who acknowledges that certain hospitals or physicians, et cetera, in his or her experience are not very good, et cetera, and that at the very beginning of your disease is sometimes also very devastating. So it has to be of help. It has to be of support, and it's certainly not covering it all. But to my experience, they are extremely helpful.
Okay, great. So it sounds as though it's very much around the right type of support and the right opportunities for experience sharing. If we move a little more broadly then, how has the prognosis for hematological disorders changed over time, particularly for elderly patients?
Yeah, there have been plenty of publications recently supporting the notion that also elderly patients have improved in their prognosis. And I think this is very supportive of the studies and exchanges and programs and looking at those elderly patients that this has probably occurred. So there's a publication from Kumar from the Mayo Clinic stating that even patients over 60 years, but you might argue that those patients are not really that old. So beyond 70 years and 80 years would also be a great benefit if those in their prognosis would also improve. But at least this publication states that patients over 60 years have improved in their prognosis as patients have always improved over time below 60 years. So that was really a very important publication. And I think that we are trying to have more studies where specifically non-transplantable patients are being put in, and where all of us are looking that the age is above 70 years, that those studies are being increasing is also very important. So the prognosis has improved also in elderly patients. The definition is, how the cutoff is being defined. It has been over 60 years, but it should be really over 70 years. And you can also rightly state to a patient that they will survive normally approximately 3 to 5 years. If they are lucky, also 5 to 10 years with the disease, as much as they endure being treated, because that is also being done more specifically, also in elderly patients, that treatment is going longer than only for 2 or 4 cycles. And if they are tolerating that treatment is inducing good effects, but also side effects might occur.
You've obviously touched there on the ability to treat for longer, the endurance of treatment. Is there anything else that's behind this improvement in prognosis in these older patients? I guess also acknowledging what you said about the age cutoff point as well. Is there anything beyond that treatment and length and endurance that's leading to that improvement?
I mean, one important issue is certainly that treatment variability has changed tremendously. So there are more treatment protocols, there are more options, what you can do in elderly patients with multiple myeloma. So there are tumor boards where you can discuss this and find the best option. I think this is very helpful. It's also the understanding that you can dose reduce in the very beginning and then increase the dose whilst the patient is responding, hopefully, and also tolerating the treatment to the utmost efficacy and least side effects occurring. And there's also the notion that if you don't want to reduce treatment upfront, and there's a very important publication by the Turin group by Alessandra La Rocca, that you can then dose reduce whilst treatment are going on. So what they have, for example, looked at was lenalidomide for specific cycle numbers in one half of the patient, not reducing the dose, trying to go on with lenalidomide and dexamethasone, and the other treatment group, which was approximately 100 patients also, they, after 9 cycles, had a reduced dose of lenalidomide, and also dexamethasone was stopped entirely. And what they could see is that not only efficacy of treatment was preserved, but also side effects occurring, and quality of life issues then also evolving were better with the reduced dose and without dexamethasone being performed in that specific RD treatment, which was the first trial, as it was called, looking at lenalidomide and dexamethasone in elderly patients as compared to melphalan, thalidomide, and dexamethasone or prednisone, which was the former standard. I would say this is a very important trial being performed. Probably it would have been even wiser if they had planned the study upfront, less len and dexamethasone already in the very beginning as compared to full dose. And they would have even seen a greater effect. But this study needed to be supported by industry, and that was probably not what they could do, although this would have been even a better study. And that is the other issue. We have to sort of invent studies that are clinically meaningful, but are also supported and can be done. So the university hospitals don't have endless monies, nor has government. And we nevertheless want to do meaningful and good studies that help our patients within the next years.
That middle ground of feasibility, yes, of course.
Yes.
If we move more to the outcomes perspective, why are the outcomes typically not as good in elderly patients with hematological malignancies when compared with younger patients?
Yeah, I think there are tons of issues behind this. So one is the patient really in the mood of fighting and tolerating whatever comes, and what might be difficult to foresee or to undergo. If you try to motivate patients and they have this drive within them, this might be no problem. However, organ function is another issue. So is the patient coming to you only having multiple myeloma, or if that patient is elderly, has also heart problems, lung problems, gastrointestinal problems, renal problem, or other issues, so that also on those organ function, you have to adjust or adapt your treatment. And then it's also the sort of different environment. So the body with all its function that is slower, metabolism is not as in the younger patient. So that treatment endurance or treatment easiness is more difficult in elderly patients than in younger. So all these issues make it more difficult for us, plus the patient and the accompanying partner, to really tolerate and perform the treatment.
Sure, you touched on things like the patient drive, the ability to tolerate treatment, frailty, other conditions. I guess from your experience, what are the most important things to consider in an aging patient with a hematological malignancy?
Yeah, one issue is certainly is that patient quite fit or intermediate or frail, as we call it. So can we have an easy test or function scale that tells us quite objectively this patient will endure treatment quite easily, or should this be done inpatient or outpatiently? Should I look at the patient more often, or is this easygoing? So if you have defined this patient is if she is older, intermediate or frail, you want to be a little slower and more carefully applying your treatment. If the patient is fit, you might be able to do whatever you like, and this will go across without any problem, side effects, and lead to the efficacy you would like to see. You also have to sort of see how well the patient understands the treatment. So do you need patient flows? Do you need a partner who understands this also? And does somebody else have to look at the patient? Do you have to sort of start in your clinic or in your private practice and see the patient every day, which is very difficult and quite cumbersome in time issues? And is that person able to do one drug or two drugs or three drugs or even four drugs? And if complications arise that you try to foresee as much as you can, is that patient also able to come to your site immediately to solve this problem and then undergo treatment again? So if all those issues are pretty clear, which do evolve over time typically, because the patients really get their expert in their disease and also how they tolerate and how this should be done, and they read and ask you a lot of questions, then whilst time are progressing, this gets better and better. So it's no longer a problem often. But there might be also very rare side effects, so those need to be addressed also. And then it's also, does the patient like to speak? And does the physician also like to speak about problems? Or is this all easygoing? So do you have a problem? No, then you go out of my department again. And then there's not even a hint of a problem that can be discussed. So it's also a time issue. Do you need to see the patient for 5 minutes, or can you see the patient for 15 minutes or 30 minutes? So it's typically that we at university hospitals are being claimed that we have tons of time. So we can certainly see a patient for 1 hour or 2 hours, whatever. We have all sorts of support programs, which we certainly have. And in private practice, this can never be the case. So all those issues of supportives are a little more difficult to perform. Nevertheless, also private practice has now acknowledged that they need to have support strategies and support persons behind their own activities, and they can help tremendously to really make sure that a treatment is being done and all problems are being solved. So I think those are all steps that are very important.
Thank you. You talked about the importance of modifying treatment approaches given the frailty of individual patients. How does frailty impact the treatment outcomes?
Yeah, frailty might at the worst lead to that you do not do any treatment at all, or you give up treatment very prematurely. That might be wise in a patient we have, for example, published where we have seen a amyloidosis patient who was very frail and very fragile also, with a very high myeloma comorbidity index, which is the higher the worst. And we treated her, and she did respond by all biological and myeloma and amyloidosis markers. So the sort of objective response was quite rewarding. Nevertheless, her frailty, her performance, her how she moved at home, how she perceived her quality of life deteriorated because she didn't tolerate treatment as much as she should have. So we adjusted treatment, and when this did not improve at all, we also decided in a circle of all experts being asked, and in our multiple myeloma tumor board, that we didn't want to continue treatment, which was also her desire. So their frailty issues and how this does improve over time or even not does help, because this may make you come to the right decision. And because we found this frustrating on the one hand, but also the right decision on the other hand, we did publish this because we thought this was important for the community. But frailty can also improve. And we have also recently published this, that frailty is certainly also induced by the myeloma disease itself. So if, for example, the performance status and frailty is improving because bone pain is no longer there, bone has subsided to the treatment of breaking and inducing pain and deterioration of the patient, then the patient can walk in, does not need a stick, and performance is much, much better. So that helps also to then increase treatment again, and also, for example, not using one drug alone, but saying now I can use 2 drugs or even 3 drugs. So this is extremely helpful, and we have seen this especially in patients who are responding well. So if achieve more than a partial response, or at least a partial response, which means that 50% of the myeloma disease is decreasing, is getting down, is coming down, or in patients below the age of 70. So in elderly patients above the age of 70, it also occurred, but to a lesser extent. So that was our age cutoff. And you could also do this with over 90-year-old patient, but our group of patients was so low that we didn't do those statistical analyses anymore. But the older the patients get, the lesser, and that is frailty again and organ function, the patient sort of grows up, blossoms again, and is not 80 anymore, but 20. So we are going not through such a river where we go in old and come out young. So that is not what multiple myeloma treatment can perform, but that the patient gets better, that can be reached. So I think that this is an important message.
Interesting cases, interesting examples. Thank you. I mean, are there any principles or things that can be done, broadly speaking, to compensate for worsening function in older patients?
Yeah, certainly a partner is always helpful, or a family member who is accompanying the patient. Also in COVID times, we have opened our hospital and outpatient facilities again so that they can join, so they can talk together and try to understand the messages better and try to perform all those recommendations you have given. It's also sort of supportives given by, for example, self-support groups or our nursing support. So they also speak with patients. We also had special multiple myeloma nurses who come around and try to solve those questions that have not been enough covered by a physician. It's also those regular meetings where those patients in self-support groups speak about what they understand or they don't understand or what they found helpful. And I try to always encourage them to speak about the good things, not only complain about the bad things that they probably cannot change. And it's certainly also, if the patient sees that she responds, that's also very, very helpful, because that makes them move along. And if you try to find answers to their problems or their organ function impairment, how this can be solved. So the interdisciplinarity of also having orthopedic physicians, also having radiation specialists, pain managers, radiologists, all those moving around the patient in a larger group of myeloma experts is always helpful. We also have a sport group. We're doing a sort of sport intervention study where we looked at a randomized cohort of patients who are being treated with sport activities of running around. So it's not jogging, it's just moving along, whether that is by foot or by bicycle or other means, and also using strength on your larger muscles, which is arms and legs, and this 2 or 3 times a week, which is the WHO recommendation of 150 minutes per week of sport activities, and compare those patients with sport intervention with those who are doing their activity as usual, and see whether patients are profiting in terms of myeloma treatment response, myeloma treatment endurance, depression, how they feel their quality of life is evolving, how often they come into hospital, etc. And there has been just a very recent publication in the New England Journal of Medicine, which is really the highest journal round that we have to read. And they looked, I think, at approximately 350 elderly patients with heart problems, so heart disease. So they were heavily heart compromised. So, for example, after heart ache or heart disease or coronary heart disease and myocardial infarction. And they also trained those patients very moderately, and they perceived very rewarding aspects, that really improvement in quality of life and performance of daily function was occurring. And my prediction is, and I'm sure this is correct, this is not only true for patients with heart disease and myocardial infarction, it's also true for tumor patients, it's also true for multiple myeloma patients. And some years ago, there was sort of the notion that multiple myeloma patients, because of those osteolytic diseases, you cannot perform any sports activities on, which is certainly incorrect. But you have to look that osteolyses are not being increased, or there is any breakage of bone, or that they have to undergo more operations because something is occurring. So accidents have to be avoided. But those intervention studies, I think, are also very important, but they are certainly money-wise challenging as well. So we have to have enough support that we can perform those studies for our patients.
Interesting, thank you. Our final topic, clearly the piece on everyone's lips at the moment. We're in the middle of a global pandemic. Everyone is inundated with news about COVID-19. Are patients with hematological malignancies more vulnerable to COVID-19, and what can be done to mitigate that risk?
Yes, this is also a very important question. So the easy answer is hematologic, and any cancer patients are more vulnerable to COVID, and they probably also get a little sicker. Nevertheless, I have to say, we also looked at hematologic and specifically cancer and multiple myeloma patients at our site as well as in Germany. And our results were very rewarding. So we looked at few, which was only 21 multiple myeloma patients in the very early pandemic of the first wave in Germany from 10 comprehensive cancer centers. And none of those patients died. So that was a very good message. And they went through the COVID infection quite easily with all the support that the German system offers to them. So antibiotic treatment, all medication that were available at that time, putting them into hospital, having a one-by-one support of physicians as well as nurses. So a very large supportive initiative that was helpful for our cancer patients. We also did a side-by-side comparison of very, very extremely well-matched cancer and non-cancer patients with both COVID, and we saw a similar outcome. So necessarily speaking, that patients with cancer and multiple myeloma always have a worse outcome and are at specific risk for COVID is probably not true in our experience. our answer to why this is the case is whilst different systems are not comparable. So in, for example, New York, the pandemic was totally differently organized than in Germany. And also sort of how much support was being prepared and also issued on those patients was very well managed in Germany, I would say. And also, our patients are very sort of following the rules. So they use masks, they look at hygiene, they don't wave their hands, they don't do any hugging. So they are very careful of what they do. And they also use their supportive medication, which are antibiotics and also antiviral prophylaxis whilst they are on treatment. So that was probably also helpful. Nevertheless, I think we have learned so much now, and the vaccination has started. Our patients are very well following the vaccination recommendations. So I would say in Germany, they have very, very few multiple myeloma patients that I oversee, but I'm also a strong believer and supporter of vaccinations that has not undergone the vaccination twice. We are talking now about the third vaccination starting in September. So I think those are helpful issues to really say, can we open the hospitals even to a larger extent? Can we probably also sometimes work without those masks anymore, because it is very strenuous and very sort of hard to talk all the time to a patient for hours with this strong mask on, and it's also difficult to sort of understand, and they are sometimes fearful of getting nearer than those 150 meters, although I would say this patient is being vaccinated, I'm being vaccinated, ventilation is going on, masks are being put on. How much do we still have to do to get over this pandemic? So it's a very big issue. There are also elections going on in Germany. So I think there's a bit of a fear to do too much opening, because some might oppose to this. But I would be a friend of opening a little more and to a larger extent, but certainly also trying to vaccinate, if I may dream, 100% of all those who are working with patients, and also certainly our patients themselves.
Thank you very much for those insights. That brings us to the end of this podcast. And thank you very much indeed to Professor Monica Engelhardt for her participation and for her excellent insights on this podcast on hematological changes in older adults. Thank you also to everyone for listening. As a reminder, this is the fourth podcast in a series of 5. To access the other podcasts in this series, along with the associated resources, please do visit the EHA campus at www.ehaweb.org. And please do join us again for the next in the EHA Myth-Busting series. Thank you for listening.